Welcome to this latest Leading with Purpose podcast. This week should be a really fascinating and fantastic podcast because we're joined by Dr. Bahman Nedjat-Shokouhi. He's the founder and CEO of a company that is transforming how we access and use the NHS and indeed the outcomes we get from the NHS, particularly pertinent as we have all of the discussion and strategy in the NHS 10-year plan about moving to online access for services, giving people more choice, virtual hospitals. It's brand new for many patients, but actually, Medefer, and we're really proud to have them part of the Purpose Coalition, have been a company that's pioneered developing this technology that we're now going to see, I think, steadily rolled out on those services and testing those models of patient care. So, Barman, brilliant to have you on the podcast. Thanks so much for that. Tell us a little bit about your own journey because you've been built by the NHS. You've been part of it yourself as a consultant. Is that right?
That's correct. Well, firstly, thank you very much for having me, and a very warm hello to all of your listeners. Thank you for having me. So, yeah, I am a gastroenterology consultant. So I specialize in gut and liver related diseases. I actually come from a medical family. My father is a retired surgeon, and my mother was a internal physician with an interest in cardiology. And the whole purpose or ethos of me was to go into medicine. I was actually meant to do academic work. I got a scholarship to do a PhD, which I completed at University College. But it was two patients, and I'm sure we'll get more into it, that really changed the course of my life from doing academics into trying to change how we deliver healthcare.
So tell us a little bit about that experience. It sounds like I think we all have these moments in life when maybe it clarifies something or makes us see something clearly. But I know for you that experience with the two patients was, I mean, absolutely pivotal, wasn't it, in showing the challenges that patients face?
Yeah, so one of them was actually my own patient, and this was a 39-year-old lady with a 1-year-old daughter. Unbeknown to me, her mother had passed away from liver cancer, having been an alcoholic. And she had a very benign condition, and the GP had done all the workup but couldn't quite explain what the problem with the lady was. She waits 11 weeks to come to the clinic, worried that she's not going to see her daughter grow up because of the experience she's had about her mother. So that is really impacting her care, breastfeeding, and everything else with this young baby. And all it took was literally 2 minutes of me saying, "There's nothing wrong with you. I'm sorry you had to wait 11 weeks to go through this." The other one wasn't one of my patients. I was asked to investigate a significant incident when a Middle Eastern patient turned up to the front of A&E with disseminated liver cancer. And it turned out that he had a liver virus that you couldn't cure, but you could treat. But he had been lost because of the paper system and the way the hospital was following this patient up. He had been lost to follow-up. And so 2.5 years later, he turns up to the front of A&E completely jaundiced and yellow because of liver cancer. And frankly, that shouldn't have happened either. And as I was reflecting on both of these patients, like one of them could have been dealt by me or any consultant really quickly and put at ease within minutes of that referral to help the GP. The other one really needed our attention, but got lost to the system. And so for me, this became a real drive of, we know these were not complicated medical conditions to deal with. So it's a system issue. How do we deal with that? And then the rest is history. And 12 years later, I'm in front of you talking.
And even for the woman who was okay, actually, had she not been okay, she still waited because of these barriers that she had for herself in accessing care. And I think, what's at the heart of both of those cases is speed of access and being able to get into the system and see the right people quickly. And so, you know, that clearly had a transformational effect on you and also your life because it inspires you to set up Medefer, doesn't it? And I mean, I just wanted to dig into this as well, Barman. So you go home that night and you're clearly really thinking about it, but not everybody would think, right, I'm going to go and do something about this or set up a business and organization that can help tackle it. It's quite a step. What do you think in you made you think I'm not going to leave this? I need to do something about it.
Interestingly, I didn't actually go home thinking I want to set up a business to fix these issues. I went home, and so my wife is also a medic, and I spoke to my wife, talked to all of my medical friends. I said, look, we need to do something. Here's an operational issue. Here's how the pathways work. And I went back, after having thought about it a little, we went back to my managers at the hospital.
Mm-hmm.
And I said, look, I think we can improve this. I've got some ideas and some thoughts. And literally everybody said to me, Bahman, you're doing your PhD, you're going to be a consultant. Why don't you just do private work and enjoy your life? It's really hard work trying to change how NHS works. And that really hit me. But I came to this to help patients. And just to be told that go and enjoy your life and be a doctor and earn private money, and it's difficult to change the NHS. So I ended up setting up the business because I couldn't do it within the NHS in the first place. And understandably, look, there is a lot of risk. How do you build an entire whole new system? If it goes wrong, who invests in it? So there's a whole ecosystem of that. I ended up setting up a business. And as I said, I came from a non-business oriented family. I came from a medical family. So I didn't even know what a business structure was when I first decided that I need to do this. But it was such a big drive, especially when I was told, just don't worry about this. There's nothing you can do. And I thought, no, I've got to do something about this. And that just became a burning fire that keeps burning.
It's so interesting because I can completely relate to that. I think at two moments, I think for me going into politics, one of those moments was when I was a child watching TV. My dad always used to watch the news, always used to shout at politicians who he didn't agree with. And my mum would say, I don't know why you're shouting. There's no one who can hear you. And I always remember thinking, I didn't like the idea that nobody could hear what my dad thought, actually. And I'm sure that was one of the things that was always in the back of my mind, people getting listened to when I became an MP. But interestingly, I also had that sense of understanding the limitations of the system. So I became a Secretary of State. I ran 3 departments, but I'm really driven by social mobility and access to opportunity. And I steadily realized that it was businesses that had those opportunities. I had a career in industry before I went into politics. And I thought, well, if lifting this bit of the rock, the system rock, is really heavy, then I'll go and find a bit of the rock that's easier. And I think that's what you did. I went out of the political system to do the Purpose Coalition because I thought actually that's how I can drive some of the change that I want to see. And I think
Very interesting, isn't it?
yeah, well, I think it's interesting when you see the ecosystem because actually, in the same way now that through the Purpose Coalition, we could feed all this innovation that we're part of back into the system. Actually, for Medefer, and we should come and talk about Medefer now, you can start to do that as we're now seeing literally right now
Absolutely.
back with the NHS. So you set up Medefer and explain to people, its sense of purpose, the mission, but also practically what's it then going to do about these issues that you think, I can't just leave that.
So the thing that for me and the team that's come around me at Medefer is very clear. By the way, this is not unique to us seeing it. People talk about this already, is how do you improve productivity? How do you make the best use of resources and the public money that goes into the NHS? How do you make the best use of the capacity that is in the independent sector for the benefit of the NHS and the patients? And so Medefer's mission is very core, is very simple. Get patients better faster. And the question of how we do that is effectively the ethos of Medefer is we want to optimize and unlock capacity wherever it is. Now that could be how the doctors see patients, and so productivity is there, how operational pathways are created. So one of the things that, for example, struck me really early on was within my own hospitals, I might request a test for a patient to have an ultrasound and a CT scan and an endoscopy. My hospital might have a waiting list for endoscopy, but down the road, the other hospital didn't have a waiting list. But we were stuck in this, what I call a legal vertical. So I couldn't send a patient to the endoscopy at the other hospital, whereas they could have sent a patient for a scan in ours. So one of the things about Medefer very early on was we need a system solution. We need to be able to aggregate the capacity of all the providers, NHS and independent sector, into one pot that benefits the patients. And if it's within traveling distance, do you really mind going to hospital A for one scan and hospital B for the other scan, as long as everything goes into one place for them to see? So that became the driving thing of, well, how do we solve a system level issue? And when we started looking at system level issues, we started saying, well, there is a primary care. How do we support primary care? So it became a really complex ecosystem of genuinely thinking, how do we solve system level problems from the very beginning, i.e. at primary care level? And we now have evidence that actually when you use it in the way that we've modeled and we work, you free up primary care quite significantly as well for them to do primary care stuff, to then make specialists more efficient and free up capacity there. And we'll go into that. But one other last example is clinical safety is so paramount. That example I gave you about that patient who got lost in the system. So we know there are waiting lists. COVID wasn't a once in a century event, but it created long waiting lists for diagnostics. So, well, one of the things that we did during COVID, every single patient under Medefer, we knew that we couldn't put them through diagnostics. So we asked our consultants to label them, categorize them by risk, red, amber, green. I understand it clinically. Patients understand it. And then the patient went through it based on clinical risk. And we said, dear patient, if you've been categorized as a green, it means the consultant isn't worried about you. But if your symptoms change, call us. We'll reprioritize you. So then you kind of dynamically manage this whole thing. So it's not just about efficiency, but how do you make something that happens once in a century, how do you make that safe and get to a better road to recovery? And we've got lots of statistics that we can go through as we talk.
I mean, and it's fascinating because, I mean, a really ambitious mission as well, but almost part of the challenge of the NHS is it's so big. The risk is that everybody is, as you described, a bit in that silo, trying to do their best and optimize within their bit. And actually, there isn't that freedom almost to be able to step out and think, right, if we were optimizing both demand and supply effectively on the patient side, on the consultant and supply side efficiently, how would we go about doing that? So I think let's fast track forward now to talk about the kinds of care now that Medefer is providing. I think some of those examples of partnerships as well with NHS, bits of the NHS, such different bits of the NHS as well, you know, including prostate cancer and some of the areas that the government's focusing on explicitly now in this NHS online strategy. Let's make this practical, if you like, for people watching it and talk about how it's going to change their version of using the NHS.
So I think that's a really good element to really emphasize that we've come from the NHS and we are here for the NHS. And so that partnership is really key. And sometimes the challenge is to help your partners understand the art of the possible. So, for example, so when in Northeast London, in 2016, the leadership in the commissioning group had a problem with waiting lists at their local hospitals, and they talked to us about what the opportunities might be. So we came with a proposal of this, what is now effectively being rolled as the NHS Online, of consultants anywhere in the country being able to assess the patients remotely where clinically appropriate with diagnostics as close to their home as possible based on what they had already commissioned. So what do I mean by that? So when we went live, GPs were referring for gastroenterology services. Local NHS hospital was already delivering, and they had endoscopy, scans, CT, MRI, ultrasound. But they already had 2 private providers delivering endoscopy that had been commissioned by the NHS to do as well. So you had multiple different providers in the region. So we basically talked to the commissioners and said, allow us to refer to use all of the diagnostics. And this became really interesting because it showed what you could do clinically for the patient. So we had, for example, a patient would get referred to us, consultant anywhere in the country would assess them. The average time from the referral to a consultant picking up was about 29 hours. Compare that to when we started, they had a waiting list problem of over 52 weeks for a first appointment. So it suddenly shortened that to a day. From there, the consultant would say, go for a test for an endoscopy, for example. And the endoscopy would take 6 weeks, 8 weeks. Now, what was really interesting, one of the things I noticed early on, and this is pre-COVID, was we had a constant waiting time of 6 weeks, which to me meant there isn't a capacity issue. If the waiting list is 6 weeks constantly, it can't be a capacity issue because otherwise it keeps growing. It's an incentive issue of bringing it back and running it even more efficiently. It's a booking issue. So then I talked to the providers in the region, and one of them said, well, if you send us more patients, we'll promise you to bring the waiting list forward. And so we talked to the commissioners and said, we don't think this will work. I said, well, it's a market. Let us try it. Within 6 months, we had waiting lists of 10 days for endoscopy. So again, confirmation.
And that was because some of those wider providers were getting on and
doing it.
getting those diagnostic done.
We just basically said, whichever one of you brings your waiting list down, we will send you the referral to you.
Yeah, and actually they're best placed to understand their capacity. So in a sense, you were allowing them to manage those risks and understand their capacities and actually, it naturally fixed itself then.
And I think this is one of the learnings. So I'll give you a patient example of this, and I want to kind of pull out a learning from that we've had, which is, so we had a situation where an early young man was referred for some reflux. In the referral, there was nothing to suggest there was anything significant or sinister going on with this man. The consultant reviewed his referral within 4 hours, said you need an endoscopy. The endoscopy happened 7 calendar days later and found early esophageal cancer. And he had a curative operation 21 days after he was originally referred. Now, even in the best, fastest possible normal pathway, let's say he went to a cancer pathway and he's waited 2 weeks, he would have been too late by the time he got to it. So there are patients who do come to harm because the care is still too slow, even at the best that we've tried to do. And the interesting learning there was sometimes, and even I reflect back to my own times at the NHS, that we have a learned helplessness, which
Hmm.
is, well, you can't bring it forward, you can't do it much sooner. How can you do it? But
So people actually get conditioned. It's a social norm. They just think, well, this is how it is.
absolutely. And one of the interesting things I've noticed is NHS is really good at doing many things, but one of the things it doesn't do very well is that it does not reward being exceptionally good.
Hmm.
So everyone reverts to being, okay, well, I need to hit these targets. Even if you could be much faster, you don't get rewarded for it. So why would you change or break your back? Because change is difficult. So there's a whole load of stuff in there that I think, from a learning, not just a pathway perspective, but from when it comes to us trying to kind of disseminate the message that, guys, there is a different way of doing this. We can do better. We can kind of come out of where we've been. So that's where I'm getting really interested now as well.
Yeah, and it's interesting because, in different worlds like business, for example, if you were setting a bonus, you'd never just have a threshold for it. You'd be like, okay, this is the minimum you need to get to. If you get this far above, it's this much. If you get, I'm of course not necessarily saying that directly translates, but there's a concept there, isn't there? Which is the reason it's done like that is because of human nature and the fact that people aim for things, and they'll aim for a threshold if we're given a threshold. So it's really about what kind of ecosystem are we all in, and that shapes the culture then. I
Taking
think
it,
the other thing I wanted to dig in for you was just you've got a variety of, I think, quite different partnerships. Some are on cancer, some are entirely, as you said, gastroenterology. They're across really different clinical needs now. What do you feel you've learned from those very different NHS partnerships that you've been involved in establishing?
so a couple of things. And before I move to that, can I just say, in terms of the reward, it's interesting to hear that when the Secretary of State for Health, Wes Streeting, initially started, he talked about rewarding the executives in the NHS in a different way for performance. So it would be interesting to see what comes from that. But in terms of what we've learned is, firstly, when it comes to clinical pathways, most of them have some very common threads and fundamentals, which is why we've been able to take what we've done and go into cancer pathways, elective care pathways, different specialities. So it's about taking a principle of how do you deliver a clinical pathway, just at slightly different targets and thresholds and what you prioritize within each of them, but making sure that you still keep the patients clinically safe. So that's one thing. So there's more in common between these pathways that originally meets the eye. So the transformation, in the way I would argue, is not as difficult once you understand that commonality. The second one is about the people working with them. It's healthcare is it's a very high trust environment. You need to know that you're going to deliver and keep your patients safe and all of that. And so the more we disseminate this message and the more people see these pathways work and are clinically safe, the more they will hopefully start adopting them. Just hearing, so the NHS England and the government recently in September announced NHS Online, which is very much similar to the services that we've been delivering. And in fact, they referenced Medefer's work as one of the tried and tested models. And it's interesting hearing people's reactions to it. Lots of questions of, how do you make sure it's safe? How do you staff it? Lots of very valid questions that we've got the answers to. We've now been doing it for years, but these were questions that we had to answer and solve. And understandably, people ask those questions. They're valid questions. And once you start to build the trust around it, you start using it.
Yeah. And in the sense that NHS 10-year plan pretty much adopts that Medefer purpose and vision of how to deliver services in a different way, and now brings it into a core NHS model, and all this, the online hospitals vision that the Prime Minister set out in his conference speech, online consultants. It's such an obvious step forward, but actually that's not a leap into the dark. This is something that a business like Medefer has been developing, carefully testing, working with and developing with the NHS for over a decade, I guess now.
Yes, absolutely. And one of the things for us in partnership when we work with the NHS is actually work hand in glove about what's working, what's not working, how to refine it, how do we make sure that the NHS genuinely benefits? So if you, for example, hear some of the stories of some of the private providers who have opened up facilities and then the NHS theatre hospitals are empty, the way that we've always worked is, no, we want to prioritize the NHS's own capacity first. Only when they can't cope with it does it then go into the independent sector, because that's the right thing for the patient. So that way it brings the stability to the NHS. And then we work with our partners around the clinical pathways, the patient communications. There's a whole wide raft of elements, training for GPs, for junior doctors, for their own consultants, because this is a slightly different way of doing. It's quite a different layers of making sure the partnership hits quite a different number of areas to bring
It's
the
it
benefit back into the NHS and the patients.
And it feels like it's very much about the Medefer's ability to augment that access to patient services and better outcomes. And I think that is a very different ethos. And it's probably worth us coming on to talk a little bit about what it does mean for access to care for patients. Because in many respects, it's potentially, as you say, transformational, because there's all sorts of reasons, aren't there, why patients might find it harder to, as it were, get into and navigate the system. And I guess it's probably worth just touching on Medefer's experience of what this means for patients, making it easier.
So absolutely, as you said, healthcare can be quite daunting. Not only is it anxiety-provoking time for a patient and their family, but it's such a big black box for a patient. It's like, my God, what's about to happen? Where do I go? And so one of the things that we've done at Medefer is at every single step of the pathway, we explain to the patient in writing where you are and what's about to happen next for you in the pathway to kind of orient them. Most people have now used Amazon, as you know, it kind of tracks your package. We try to explain to the patient, this is which part of the pathway you are in, what you need to expect next from it. So that's one, to help them orient themselves around it. We've trained our admin team, the frontline team, to be almost like a concierge for the patients. It's like, this is the kind of language you need to talk to understand that. So there's an element of training for them as well, which is difficult to do. The other part is about the speed of access, is obviously, as I've alluded to, you can get much faster access to consultants. One of the questions that has come up around the NHS Online, for example, is like, well, do we have extra capacity for consultants already? Aren't they already working? And one of the things that we've now clearly demonstrated is consultants want to give time back into the NHS. Quite a large number of consultants who do not do private work at all, but they don't want to spend 4 hours in an evening clinic or a Saturday morning as well, but are quite happy to give pockets of time, what I describe micro time. And when you start putting these together across a week, that equates to a traditional 12 hours worth of additional clinic capacity. So there is an enormous amount of untapped clinical capacity already there to just be brought back into the system. So that's one of the ways of things that we do.
And I guess, people talk about NHS burnout and people getting so frazzled that they end up perversely leaving the system. And so this is a way, well, I guess it's like for everyone, isn't it? It just gives consultants a way to flexibly stay part of delivering NHS services
We've got a consultant who
in a
is,
more modern world that they'd expect more flexibility. We all probably would in many of us, many of our roles.
we have a consultant who's gone part-time for family reasons. NHS has lost some of that capacity that she used to deliver, but now she does that back into the NHS. So when she goes to pick up her children, she knows that she's got that flexibility, and I can give half an hour here or 20 minutes there. And all of those add up when you put them back in.
Yeah, and they're so valuable as well because those consultants, the years of training, the experience,
Exactly.
it's really
Without having to train a whole layer of consultants. So it's already there. So let's tap into them. And it's refreshing to see the government talk about it. West Streeting was on the news the other day, talking about exactly that. And lastly, you talked about access. So patients traditionally have been brought for face-to-face consultations, even when clinically it's not been needed. Now, the NHS has for a while been talking about trying to prioritize remote. NHS England has certainly been. Sometimes consultants have not been comfortable enough about it. Sometimes the commissioners haven't opened the pathways necessarily. But when you start doing this kind of work, especially when you've got people who are carers, either for their children or disabled, it's like we had a patient who wrote a beautiful 5-page long letter of how difficult she found it to go to her physical appointments because of physical and psychological issues that she has. She just doesn't like being in large crowds, etc., etc. The flexibility of being able to see someone remotely just freed her up to be looked after. The other thing is,
Well, I think interestingly, sorry to interrupt, but interestingly,
sure,
a lot of this debate is, well, it's just people for convenience. There's nothing wrong with it being more convenient. Lots of people are busy. If it means they can stay and work that day and not do effectively 3 hours out plus, that's a good thing. But the point you're making is for a lot of people, the ability to do that easier online consultant access is absolutely key to them getting access. And
100%.
and it's a healthcare issue in and of itself and a barrier that you can remove. So these are not simple, I prefer it to be online. Actually, for there's a
Health related.
significant number of people, and they're probably the people most likely to be in the NHS system, for whom this is actually making it a lot easier and better and less stressful to be able to access the care they need.
We have a service in Staffordshire for the NHS that we've been commissioned to deliver, and we've been there for about 2 years now. And we looked at the data of access. And when you look at the two most deprived patient population groups, Staffordshire has a large proportion of those. We've now demonstrated you can improve access for that two most deprived patient population groups by 44.6, nearly 45%. That's an enormous improvement. These are people who would, if they took time off to go to clinics, probably be on an hourly payment. And actually, the NHS had done some studies just before COVID that there's about an 84, 85 pound economic impact of a patient just going to a clinic. Translates into taxes back into the country. So there's like a whole thing. So that's when I talked about system effect at the beginning. It's like we started pulling on one thread. It's like, hang on a minute, that keeps going. So let's start pulling it all back together and paint the system picture.
And I think that social mobility piece is so crucial. I mean, we know the link between socioeconomic outcomes and health outcomes. The causality runs both ways. So this is, I think, just a crucial step forward. I think it's so much more than just convenience, but also for people who do want a more convenient approach, why take up space in a face-to-face setting that somebody else might themselves really need much, much more and
Absolutely.
absolutely prefer. So everybody, in a sense, gets the version of that consultant access that is best for them, and that is surely better for patient outcomes, I guess.
So as you said, clearly, patients who need to be seen in person will have a shorter waiting times. Patients who clinically safe and appropriate and are happy to be seen remotely can be seen quicker. And actually, one of the interesting other things is you will be hard pushed to find a consultant prepared to do clinics until 10 o'clock in the evening face to face. But we run them 365 days a week remotely. So suddenly you have a much greater range of appointments available to patients who might get home after a long shift and suddenly have the available slot that would have otherwise been almost impossible for them to get.
And including childcare responsibilities and all sorts of times when it is really not that convenient to have to drop everything and head into a hospital, which anyway, for people living in more rural areas, might involve multiple bus journeys that take ages, that maybe stop early evening when they're not sure if they're gonna get that last bus back. A taxi just isn't viable, and
One of the common situations I had when I was doing my own clinics was a patient who had physical mobility issues, had a hospital transport, who was running late and therefore or stuck and got in traffic, and they would arrive having effectively missed their appointment, but by arrived an hour late to the hospital, and somebody would say, "Could you please find a way of seeing them because it's really difficult to bring them back into the clinic?" And it's like, well, I'm now in endoscopy. How am I going to go and see this patient in clinic now? But for the sake of the patient, would try to get, could you please cover me? So it's like the whole thing that happens in the hospitals. You start, that patient didn't need to go necessarily unless they need the physical examination. So there's an enormous amount of impact across the system and for patients for this.
So huge steps forward, but constant innovation from an organization like Medefer. So it's probably worth just touching now on how you approach that innovation, because I think what comes across from this discussion is it is utterly patient centered. It is utterly NHS centered in a sense, rooted in augmenting and improving that core NHS system that most of us overwhelmingly rely on. And do you, Barman, do you feel that gives you a different approach on how you're innovating when you're looking at where you take all of these different services next?
I think it certainly does. And there is another element in our innovation approach. So as I mentioned, I've done a scientific PhD. So I've got that academic rigor, and we're pretty clinically led at Medefer. So not only I, as the founder and chief exec, I'm clinical, but we've got a director of primary care who's a GP himself. We've got a chief medical officer. We've got a medical director. So we're really heavily clinically led, but we bring in a scientific approach as well. So we look at a problem and say, well, what are the different things that we can do? And then we experiment. We literally measure data. It's like, well, we know the patient has to be at the center of it. So let's make sure we get patient feedbacks. Now, in the NHS, quite rightly, we have a friends and family test. Within Medefer, we offer a patient a telephone call to get a much more detailed experience examination from them after every single appointment. So we have a much richer data set of what worked, what didn't work. So everything is very data driven. And it's like, did this work? Did that not work? Are we getting the right outcomes of what we expected at the beginning? What do we need to tweak about this? Talking to our partners in the NHS, is this working for you? Do we need to change the clinical pathway slightly differently? Do we need to change the paragraph in the letter to the patient because they don't fully understand it? So it's a really rigorous set of processes and that we go through on what is working, what needs to be improved, and keep innovating. And the key elements within Medefer is, I think there's we actually look at innovation in two aspects. One is a continuous improvement process. But sometimes we look at it and saying, do we need to just throw what we understood before and look at it from a completely fresh pair of eyes because that's what makes sense? So we constantly ask that question. Do we need to redesign the whole thing?
It's so interesting because, I just reflect back on, I spent 5 years working in pharmaceuticals. I'm a finance person, but I was working in the R&D part of a big pharma company and with the scientists, basically. And in a sense, it's that same approach, isn't it? How, in their case, they're looking at, drugs and if you like, the molecular design and how it's absorbed by the body, all the outcomes, all of that kind of conventional drug discovery process. But actually, you're doing the same for that broader healthcare process and looking at the outcomes and why wouldn't you do that? And actually, a bit like those pharma companies have those massive R&D units that are trying new stuff, seeing what it means for patient outcomes. In a sense, Medefer can play that same role on
Since
that
our founding, we've spent over
wider NHS process and tech, and you can really start to help raise the game for an entire system, I guess.
100%. Well, since our founding, we've spent over 20 million pounds just in R&D. And that goes back to the original point I made, which is I can understand why I couldn't have done it in the NHS. It takes an enormous amount of resource and it could go wrong. So you almost need the private side to do the R&D and the investment and prove it works before you want to put public money behind it.
Which is the same in drug development. You think about that, probably tens, hundreds of billions of pounds that
Exactly.
ultimately come to nothing, invested in drugs that just don't improve things. You would never want that done publicly. The risk levels around it mean that the private sector is just better off doing all of that. It's got more freedom. But actually there's a big similarity in a sense to the role that Medefer could play, I guess.
Exactly. Exactly. It's a nice thing about how the private sector and, if you like, the capitalist system of, well, if it works, you take the reward, but if it doesn't work, well, you've gone bankrupt. But you've put the investment, and then the NHS can learn from it, the public sector can learn from it without putting the public purse at risk.
And also, and it can focus on what it needs to do right now, which is
100%.
deliver healthcare for a whole country. And, I think that's what's really interesting is having that role, but crucially having worked so carefully and thoughtfully through that partnership. I think that's really been the key to success. But it's probably worth just finishing the podcast by looking ahead in terms of what's next for Medefer and how you define success, where you feel this is going to go. The NHS is now moving into a 10-year plan that I think really starts to give the whole ecosystem, if I can call it like that, a longer term vision, perhaps for the first time, really, and real clarity of those big shifts from hospital to community, analog to digital, treatment to prevention. It's really straightforward for I think everyone in the system to get a sense of where it's going. What does success for you look like in the context of Medefer's role in all of this?
So interestingly, I think there's already a level of success in what we set out to achieve, and I'm
Mm,
really proud of it.
mm,
When we first set out Medefer, we haven't talked about it here, is my vision was to create the national grid for elective care,
mhm.
where any consultant anywhere can see or treat a patient, and the NHS hospitals are the real power stations, and individual consultants can sell excess capacity back into the system, and it's the grid that controls where it goes. So that was my vision. To see that NHS England and Department of Health and the government are now adopting effectively what we set out to do as part of the NHS Online and referencing it is a very proud moment itself. So small tick there. I think the big point now is, how do we take this, really adopt it, get the message out there, make sure people realize it is a safe model. But at the same time, look, whilst even though the government has referenced Medefer's work in the announcement, we're not part of the building of the NHS Online, but we've had a lot of learnings of what you need to do right and what could go wrong, and therefore how do you need to monitor it and keep it safe. So I'm really keen that we start disseminating this learning at every level so that we get the best. Now, I'm not suggesting we have all the answers, but we have a lot of the answers.
Yeah, and you have your experience.
Absolutely. So I'm keen that we share it so it doesn't go to waste, and it can be used for the best possible use. And we keep innovating. So the other areas we're now looking at is, how do we free up the GPs even more, and where do the neighborhood health? There's a whole load of areas that we're working on and exploring as well.
So exciting. And I think, a real, against what has been a really tough backdrop for the NHS, a real, I guess, sense, Barman, of optimism for what's ahead.
100%. Look, I think where the NHS 10-year plan is going, where the government's pressing ahead with the real change and transformation, there is an enormous amount of opportunity to improve the entire country's health. So it's very exciting times ahead.
It's fantastic. And we've loved having you on the podcast. So, Dr. Bahman Nedjat-Shokouhi, thank you so much for being part of the Purpose Coalition. And it's been brilliant, I think, being able to talk a lot about where Medefer fits into this NHS 10-year plan. And if you like that journey you've been on, it'll be absolutely fascinating, but also really exciting to see where it goes next. So thanks very much for being part of this.
Thank you so much for having me. It's been lovely.